Hi, my name is Haley Olds. I'm currently a dermatology resident, and today we're going to be talking about the dermatopathology basics. This is really geared more towards first year dermatology residents that are just starting out in their residency and medical students that are on their dermatology rotations. This is going to be broken up into three parts. So the first part is basic cell types and basic structures. The second part is where on the body the biopsy is from. And then the third part is most common diagnoses in derm path. Usually I would give this lecture live, but this is obviously a recording. So I will pause for you to think about it a little bit and feel free to pause the video as well. After you think about the slide, I will give a couple of hints and key findings, and then I'll give the diagnosis and go over why that's correct. So we will start with the cell types and basic structures. So what kind of cell is circled here? So major things to note here is that these cells have very pink or eosinophilic cytoplasm with granules, and some of them it's hard to tell, but this one is a pretty good example here. You can see that they have bilobe nuclei. So these are eosinophils. Okay, what kinds of cells are these? Okay, so we're still in the white blood cell category, and these have multiple lobes to their nuclei, and they kind of look like little ants. So these are neutrophils. What about these cells? So major things to note here is that the nucleus is really pushed to one side of the cell and the cytoplasm's on the other side. And then, so they call that eccentric nuclei. And then some of the nuclei look like a clock face as well, especially that one that I just circled. So these are plasma cells. What about these cells? So these cells are pretty small. I know it's hard to tell in this situation because they're the only cells there, but they're small and the nucleus is taking up the entire cell. So these are lymphocytes. It's hard to tell if they're B cells or T cells. You would need special stains really to distinguish that. Okay, now we're out of the white blood cell category and more into skin cell category. So what are these ones that are circled? So this is the basal cell layer. And then here's the dermis. So these are not every cell. They're kind of like one every five cells, and they have perinuclear clearing. So these ones are melanocytes. And they're normally at the basal layer. There's a big misconception that they're the ones that are brown, but if you remember, they're making the melanin and then passing it off to the keratinocytes. Okay, on to glands. What kind of gland is this? There's three main kinds of glands that we see in dermatology, and they are eccrine glands, apocrine glands, and sebaceous glands. So the way I always remember this one is that these have big, round, open lumen that look like O's. So these are apocrine glands. And these are found more in modified skin, so the axilla, the anogenital skin, nipple, the eyelid, places like that. What about this one? So this one looks kind of similar, but the lumen is a little bit more collapsed or folded over. And these are eccrine glands. These are found pretty much everywhere except for modified skin like nails. And then what kind of gland is this? So this has like the foamy cells. So these are sebaceous glands, and these are usually associated with hair follicles. So they're pretty much everywhere except for the palms and soles where there are no hair follicles. Okay, and then this is just a quick review of the layers of the skin. So first we have the stratum corneum up here. There's usually no nuclei there. If there are nuclei, that means that there's increased skin turnover, and that's called parakeratosis. And then it's thicker in some areas of the body, which we'll talk about. And then this layer here that looks like it has little granules is the stratum granulosum. So it's aptly named. Then most of the epidermis here is stratum spinulosum until you get to the very bottom layer, which is the stratum basale or the basal layer. And then after that, you have the papillary dermis, which is um, in between the reedy ridges. The reedy ridges are these little outpouchings here. And then you can't see it in this photo, but below the papillary dermis, you would have the reticular dermis and then the subcu fat under that. So these are very helpful and they help us to determine, when they're altered, it helps us to determine what disease process is happening or where you are on the body. So now we're going to talk about anatomical sites and how to identify them on DermPath. So where do you think this is from? So these are all hair follicles and they're going pretty deep. They're going down into the fat. So that means they're more terminal hairs, not just vellus hairs. This is some smooth muscle, the erector pili muscle associated with hair follicles. And yeah, you just have a ton of hair follicles here. So this is the scalp. And then you also see sebaceous glands associated with the hair follicles, like we said before. Okay, what about this one? So things to note here, you have a little vellus hair with associated sebaceous glands, pretty sebaceous area. This here is what's called solar elastosis, which happens with sun damage. And then you have a relatively thin epidermis here and a nice, what we call basket weave stratum corneum. So putting that all together, you are on the face. So sometimes you can see Demodex mites as well, usually in the hair follicles. And then if you're on eyelid or ear skin, you'll see more vellus hairs than just like, your forehead or your cheek. And then when you're on the eyelid, you can see skeletal muscle. And if you're on the conjunctiva, you can see goblet cells and no stratum corneum. Okay, what about this one? So again, you see a good amount of hair follicles here. But then you also see this big pink material here, which that is skeletal muscle. So if you remember what I just said on the last slide, when you see skeletal muscle this superficial, that means you're on the eyelid. And another thing about the eyelid is it has the thinnest skin and the thinnest stratum corneum or thinnest epidermis. So those are good things to keep in mind. And then if you're on the conjunctiva, like I said, you'll see goblet cells and no stratum corneum. Okay, what about this one? So the major clue here is what this structure here is that I'm circling. So that's very purple, and that is what cartilage looks like. You also see a lot of these little hairs and a lot of fat. So this is an ear. So ear biopsies are usually when we see cartilage, because the cartilage is relatively superficial and you see a lot of those little vellus hairs. Okay, this one's a little bit trickier. Where do you think this was taken from? So major clues here is you see all of this in the dermis. This is all smooth muscle. So you have to think about where you would see a lot of smooth muscle. This is also a special kind of duct, which we'll talk about in a minute. And then this is what we call an epidermis that's papillomatous, and that means like it goes up and down a lot, like little papillations. So this is from the areola, and that gland was a mammary duct. So you see a little bit of acanthosis, which means thickening of the epidermis, and a little bit of basal layer hyperpigmentation. Sometimes you also see a central invagination of the epidermis that leads to a hair follicle and sebaceous glands, but you just see a lot of smooth muscle, and that's your main clue here. And you may also see apocrine glands. Okay, what about this one? So main things to note here is you have a very thick stratum corneum, and then you also have this little lighter layer at the bottom of the stratum corneum, which is the lamina lucida. And then you don't see any hair follicles here as well, which is another important clue. So this is either a palm or a sole. So you see very compact hyperkeratosis. Hyperkeratosis means that you have increased stratum corneum, no hair follicles, but a lot of eccrine glands. Because palms and soles are they have the most eccrine glands of anywhere. Okay, another tricky one. So big things to note here is there's no stratum corneum there. Your keratinocytes and the stratum spinulosa are very pale and, plump. That's because they're full of glycogen in this location. And then in the dermis, you see a lot of very dilated blood vessels. So when you don't have stratum corneum, that means it's somewhere where the skin is well, where the epidermis is really smooth. So this is mucosa. It's probably the lip, but it could be another mucosa. Oh, there's also no granular cell layer. So as a recap, there's dilated blood vessels in the submucosa. The keratinocytes are large and pale because they're filled with glycogen, and there's no stratum corneum, or the other term for that is non-keratinizing. And you may also see salivary glands, and there are no hair follicles here. Okay, now we're going to move into the most common diagnoses in germ path. So we're going to have some tumors, some rashes, just the most common things that we see. So first one, so what do you think this is? So the biggest things to note here are you have islands of blue cells and they are lining up at the periphery. See how here they're lining up? Here's a good example of them lining up. That's called peripheral palisading. You see it's kind of pulling away from the stroma, which is all the pink part. And then the stroma is a little bit more bluish than normal. So that's called fibromyxoid stroma. So putting this all together, this is a basal cell carcinoma. So there's a lot of different variants, which you'll learn as you go through your training. The first step is just recognizing those basic features of basal cell, which is the peripheral palisading, retraction, and the islands of blue cells. Okay, next one. So, things to note here. So, over in this area, you have relatively normal epidermis. And then next to it, to the left, you see that the keratinocytes are really big and pink, and they're invading into the dermis and they're forming these structures that are called keratin pearls. So, this is an example of squamous cell carcinoma. So you see atypical keratinocytes that go into the dermis. You may see acantholysis, which is basically the keratinocytes breaking apart from one another. You can also see desmoplasia, which is when you get increased collagen in the area. And there's also, for this, a lot of different subtypes that you'll learn as you go through your training. Okay, next, this one's a little tricky. We're still in the tumor category. So, similar to the last one, all of the keratinocytes in the epidermis look abnormal. Normally, you see the keratinocytes flattening out as they move up the epidermis, but here you don't. And sometimes people say, like, if you were to flip the slide upside down, the keratinocytes on the top and the bottom look the same. You also see some mitoses that I'm circling here that aren't normal to see. And then there's parakeratosis as well. However, unlike the last slide, it's not invading into the dermis. It's just staying in the epidermis. So this is Bowen's disease or squamous cell carcinoma in situ. And that's defined by full thickness atypia in the dermis, but it doesn't go into the dermis. Versus an actinic keratosis, I'm going to go back to the last slide. So actinic keratoses, you just have atypia in the lower third of the epidermis, and then above that would be normal. So that's the difference between an AK and squamous cell in situ. Squamous cell in situ is the whole epidermis versus an AK is just the bottom third. Okay, next, you aren't seeing the whole lesion here, but give it your best guess. So up here we have normal epidermis, normal dermis, and then we have the epidermis again, and we have a lot of this loose, flaky keratin. And you have to imagine that this thing would go around and form a full circle. It's just hard to get on one slide here. But this is what an epidermoid cyst looks like. It's the most common kind of cyst. Some people call it sebaceous cyst. That's actually a misnomer, and we always call it epidermal or epidermoid cyst. So the lining of the cyst looks like the normal epidermis, but there's no adnexal structure, so there's no hair follicles, no eccrine glands, or anything like that. And it's derived from the follicular infundibulum epithelium. And then you see that loose lamellar onion skin keratin within the cyst. Okay, this one's a little bit tricky. So in this case, you can see that it's a proliferation of the keratinocytes of the stratum spinulosum. But unlike that case of Bowen's that we just saw, these keratinocytes look normal. They have small, normal sized nuclei, they have normal cytoplasm, we don't see mitotic figures. We also are getting these structures, which are called pseudohorn cysts. And then we also see the papillomatous or mammillated type architecture. So, since there's no pleomorphism or mitoses, this is in the benign category. So it's a benign proliferation of keratinocytes. This is a seborrheic keratosis or SK. So there's a lot of different variants too. This is just the most common kind, and this is one of the most common things that we see. A lot of times they send them in to rule out melanoma because they're big, brown, ugly. Here's just another example of it, of how it can look. This one still has that nice, like mammillated architecture. And it's just a proliferation of keratinocytes, but it's not going deeper down. It's not invading into the dermis. Okay, great. So this one is another cystic space, as you can see here. But this time, instead of having that loose onion skin kind of keratin, this has that thick pink keratin in the middle. And then it has a couple areas of calcification. That's like the dark purple areas. And the wall here looks like the epidermis again, but there's no granular cell layer here. This is what I would consider the second most common kind of cyst, at least that I see in clinic, and it's usually on the scalp. This is a pilar cyst. So you might see calcification, you see that thick pink keratin in the middle, and there's no granular cell layer or granular layer in the wall. Okay, next one. So this is again a proliferation of keratinocytes. These are just keratinocytes that are getting a little elongated. These are the reedy ridges. They're getting elongated and they're getting more pigmented. Some people call this a dirty socks appearance. But again, the nuclei look normal. There's a normal number of melanocytes here because these are the melanocytes, the ones with the perinuclear halo. So you can see they're still pretty like sporadically spaced. That one's going up a little bit, but in general, there's a normal number and they look normal. So this is not a melanocyte proliferation, despite that it's pigmented. This is a solar lentigo. Sometimes you can see an increased number of melanocytes, but it's really more of a keratinocyte thing. And sometimes you don't see it here so much, but you'll see solar elastosis in the dermis as well, which clues you into that they've had sun damage and that this is lentigo. Okay, next one. So in this case, we have cells that are forming nests. There's nests all over in the dermis, and they're getting smaller. Like they're smaller down here than they are up here. So that's called maturation with depth. And they're kind of going down this hair follicle here. But they all, they don't have large nuclei, they don't have pleomorphism. So this is an intradermal nevus, and these are melanocytes that are forming the nest. They're more pink than the basal cells are. The basal cells are more blue. So these are well-defined nests of melanocytes in the dermis. They're getting smaller as you go deeper into the skin, which means maturation with depth. So in this case, it's intradermal, so there's nests only in the dermis. So that's an intradermal nevus. If there's nests only at the dermal epidermal junction, that is a junctional nevus. And if the nests are both, then it's called a compound nevus. So how do you tell if it's a dysplastic nevus or not? So I have a picture here that will help us to explain some of these things, and then I'll go back to that last slide. So one thing you see bridging between the reedy ridges, you see fibroplasia. So see how this is more pink here? That's fibroplasia in the papillary dermis. You still see them pretty well nested, the melanocytes, but it's on the tips. So down here is like the tips of the reedy ridges and on the sides of the reedy ridges. Um, and then sometimes you see club shape of the reedy ridges. Let's see. Let's go back to that last slide and make sure I didn't miss anything on that. Oop, oh, too far. Okay. So, oh, and then there's also something called shouldering, which means that if this is your dermal epidermal junction, and you have nests in the dermis, you have nests at the dermal epidermal junction. This means shouldering means that your junctional component extends at least three reedy ridges beyond where you have a dermal component. So here it's junctional, 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 three beyond where you have the nests in the dermis. And that's a tough concept that makes more sense the more times you see it. And then you can have club shape hyperplasia of the reedy. You can have nests with bridging of adjacent reedy. The nests are at the tips and sides of the reedy ridges. And then you have that papillary dermal fibrosis that we talked about. Okay, so then how do you know if it's melanoma or a nevus? So things that you should always ask yourself, is it symmetric? Is it well nested? And are the nests equal in size and shape? So, and then some other things is like they don't get maturation with depth. And then you may see the melanocytes, instead of staying at the basal layer, you might see them going higher up into the epidermis, which is also concerning. That's called pagetoid spread. So here's an example of melanoma. So I'll show you some things. So like, see how this nest is so much bigger than this nest? And like, you have some nests here, but then you also have this big skip area where there is no nest. And in these bigger nests, like the cells look bigger too, and the nuclei look bigger, and you might even see some mitoses here. And then I'm seeing if there's any melanocytes that are going up. Maybe here there's a couple going up. Sometimes you don't even see the melanocytes nesting. Like here, it's kind of hard to say if they're nesting or if they're just hanging out there. You'll just see, we call it confluence of melanocytes, where they're just kind of taking over the basal cell layer. And then like here, this is probably the deepest nest we have here, but the cells aren't smaller than the ones at the dermal epidermal junction, so they don't have that maturation with depth. So those are all things to keep in mind and things to look at when you're looking at melanocytic lesions. Okay, hard part is over. I mean, this is still hard, but on to something that's not melanocytic. So here, some of the major things to pay attention to are these cells here that have these little crinkled up nuclei. Some people say they look like raisins. So those are chondrocytes. And then you also have hyperkeratosis here, which may be a part of this, or it may be because you're on the hands and the feet. And then you also have these dilated blood vessels at the papillary dermis. That shows black dots when you look at them clinically sometimes. So putting all of that together, this is a wart. So again, it has that papillomatous architecture. You have an increased granular cell layer, which you do see here too. Let me circle that for you. See how much granular cell layer there is. And then you may see those kelocytes as well. Great. Okay, now we are shifting gears into the rash category. So this is a broad kind of rash. I'll let you think about it. And then, okay, so things we're seeing here. So the epidermis does look a little bit thickened. That's called acanthosis. And then the biggest thing is see how you see all these white spaces between the keratinocytes? That is called spongiosis. So this is spongiotic dermatitis. This is like more of a subacute. There's also acute and chronic. So you see the edema between the keratinocytes kind of pulling them apart. And then you see thickening of the epidermis and parakeratosis, which is when you get that retained nuclei. This isn't the best example of it, but you can see that. And then you may see some lymphocytes crawling up into the epidermis as well. So things that can cause this: atopic dermatitis, contact dermatitis, stasis dermatitis, tinea, pityriasis rosea, all sorts of things. If this was more of an acute, you would probably see more like vesicles in the epidermis. So that's like, they got poison ivy yesterday. And then chronic is more of like that lichen simplex chronicus from, just years of rubbing and eczema there. So that you see, it kind of looks like palms and soles in that case. You get the really compact stratum corneum, and sometimes you see a stratum lucidum. Okay, great. We're still in the rash category. So, things to note here. You have thickening of the epidermis, acanthosis, but it's very regular. It's, boom, boom, okay, boom, 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 but it's not like, all over the place. It's pretty regular. And then you also see some parakeratosis for sure, but you also probably see some neutrophils that are hanging out up there in the epidermis, and that's like when that little ant part comes into play. And then you also see that there's dilated blood vessels in the papillary dermis, and the epidermis is thickened overall, but right above the papillary dermis, it's a little thin. And that correlates to something called the Auschwitz sign. So if you peeled this crust off, it would start bleeding because those vessels are like right there. So this is psoriasis. So you see neutrophils in the stratum corneum, parakeratosis, neutrophils in the stratum spinulosum as well. You see those dilated blood vessels in the dermal papillae, the regular acanthosis, and you see decreased or absent stratum granulosum. Okay, this is the last one. So, things to note here. This is all lymphocytes. You can almost say it's like a band like infiltrate, and it's right at the border between the dermis and the epidermis, and it's destroying the bottom or the basal cell layer of the epidermis. You also see these brown cells. This is pigment dropout. So when they chew up those basal cells, the pigment just kind of falls. I know this looks like a blister or like a vesicle here. It's artifact. They actually call that Max Joseph spaces, and that's because it's just destroying the basal cell layer. So that's why it looks like that. Um, you see like a little bit of hypergranulosis here too. So this is lichen planus. Oh, and then you also see the sawtoothing of the reedy ridges. So what that means is like they get kind of pointy here because they're being destroyed. So that's sawtoothing. Um, and then you see that increased granular cell layer, and then you see that's supposed to say apoptotic keratinocytes. So those are keratinocytes that are kind of dying off because they're getting eaten up. So like those are going to be bright pink. So like there's one. Um, that's probably one. So those are called Savat or colloid bodies, kind of depending on where they are. So that is it. Thank you very much, and let me know if you have any questions.